Good evening, everyone. Once again, so this is a long topic and a very vast topic. I cannot do justice to this topic alone. So I have made a brief overview. Basically, I will not be going in detail of the this whole of the sequencing and the studies. So what is more relevant in the our practice, we will try to look at the data there. So, So colon cancer, we all know, is more than one disease. It is, we can either divide molecularly or anatomically, but now a new subtype is coming, stool flora type. We can discuss like MSI wise or RAS wild type or BRAF mutant or wild type or anatomical right versus left type. So what are the current paradigms in the metastatic colorectal cancer as of today? We know it is a heterogeneous subset again. Some patients are there with limited stage 4 disease which have potentially can be converted and can be cured by interdisciplinary approach. The addition of biologicals to chemotherapy has improved the outcomes, but to a more limited extent than hoped. The identification of molecular predictive markers is improving. The potential for individualized therapy attempts are underway to expand the role of immunotherapy beyond treating patients with MSI high CRC. So if we look at the proportional impact on magnitude of OS benefit across different lines, we see in first line, second line, third line, first line, it's to the tune of approximately 2 to 4 months, the median survival increases. But as the lines increases, the proportional benefit decreases. So in third lines, it barely comes to 2 months. So again, at the same time, with in each increase in lines of therapy, the survival increases. So we should try to expose the patient to all the active and approved agents as long as patient is fit, and we should try to continue with some form of systemic treatment till the time the situation allows us to do so. So if we look at the evolution of the personalized treatment and improved survival, again, in chemotherapy alone subset from 12 to 16, 18 months, we have gone up to 39, 40 months of survival with different treatment options available to us as of today. So what are the key factors that influence the treatment selection? The systemic treatment basically either can be characterized based on tumor characteristics or the patient characteristics. It is not the one thing which we need to take into consideration. It's a multiple factors, and it is a combination of so many other things which are not there. Like as I said, social support earlier. So tumor characteristics. So importantly, what are the things that influence our treatment choices? It is the patient characteristics like age, comorbidities, what was the prior adjuvant treatment that the patient has taken, what is the PS of the patient that we need to rapid check at every step. Then the molecular characteristics like the RAS, RAF status, HER2 status, MSI status. Then the tumor characteristics. What is the burden of the tumor, which Dr. Senthil showed very nicely. The discussion was very good. It covered almost all the aspects. Whether we can take it out at some point of time or location, another right versus left-sided tumors. And again, if it is rectum, where is the it's situated, whether it is going to compromise the quality of life, and what is the patient preferences, the quality of life versus the toxicity. As we continue our treatment, we know some form of toxicity is likely to come. So the patient who is very motivated at the beginning may not be so once 2 or 3 lines are given. So we need to tailor the therapy according to the individual patient. So there is no one therapy which can be recommended, or there's no one algorithm with which we can proceed. If we look at the drugs, we have the luxury of so many options. So how do we personal therapy? So it may be for the same type of disease, same volume of disease, the options may be different depending upon all those previous factors. So personalized medicine definitely has increased the number of benefits in the patients. Determining a patient's biomarker status helps us in a number of ways in optimizing the therapy selection, reducing the prescribing trial and error, preventing adverse drug reactions, improving the quality of life, increasing the adherence to the treatment, and at the same time managing the cost of healthcare. So two important pathways, EGFR and the VEGFR pathways are there upfront, which we can use depending upon the comorbidities and the contraindications. So what are the recommended targeted therapies as of today which are available to us? So this is the armamentarium which we have. We have anti-EGFR, cetuximab and panitumumab. We have VEGF inhibitors, anti-VEGFs, which is bevacizumab, aflibercept, ramucirumab. We have TKI like regorafenib. Immunotherapy is there for the MSI high patients and chemotherapy backbones. Folfiri, Folfox. We can give Folfoxiri, Capox, TAS102. So these are the agents which are available to us. So at the same time, our increasing understanding of the complex tumor biology, it is giving us the opportunity to optimize the treatment. Basically, it is a continuum of care. By using and personalizing, we can give and sequence our treatment better. So tumor location and mutational status definitely is the key. So, and again, we need to remember one thing, RAS mutational status is dynamic over time. If the patient was like having RAS wild type, may develop mutant clones and they may disappear later also. So, first line treatment decision is paramount because we know as the treatment will progress, the patients will default, they will progress, and they may not be fit for the subsequent lines. At the same time, the responses they start to decrease with each subsequent line, like 38 to 40 to 60, 70%. The first line decreases to just barely to 20% in the third line, which is again quite high. And with each passing line of therapy, not only the numbers are going down, but again the PFS also decreases. So guidelines and the experts they acknowledge tumor location is a key decision factor that we all agree. And so sidedness matters. So clearly differences exist between left and right-sided tumors. It may be microbiome related or biological environment related. They may be because of the genetic mutations or maybe within the GI system. So this we discussed yesterday also. There is differences in right versus left. So again, in choosing a therapy, we need to choose our goals of the care very carefully. How aggressive we need to be, whether aggressive combinations to give to maximize the survival. And again, it will depend upon the tumor location and the molecular profile. Of course, the other characteristics like patient comorbidities, everything is there. So first line therapy, this is basically a chart to directors. This is a brief what we are going to use in first line can be given in, and subsequently what can be used and what are the options available to us as of today. So, so as Dr. Senthil sir had asked in the previous discussion, is there a benefit of triplet chemotherapy, Folfox, Folfiri, Folfoxiri? So this was the type 2 study which sir was alluding to. So the patients with unresectable metastatic colorectal cancer less than 75 years of age, ECOG good, and no previously treated with oxaliplatin, they were randomized to get Folfox plus Bev 8 cycles versus Folfoxiri plus Bev, and on progression on Folfox, Folfiri was given with the same regime. With bevacizumab and in the arm B, the Folfoxiri was reinitiated on progression. The primary endpoint was PFS2, and this is how the data showed. So clearly, the triplet was better in the patients who were able to tolerate it. We can see there was a difference in OS 27.6 versus 22.6. And important here is if we look at here, the PFS uh, in the triplet time, it was 8 months. There was the treatment duration, and uh, maintenance therapy was the PFS 5.6 months versus 6.2 months in the experimental arm was better. So the tumor location may impact outcomes. Triplet chemotherapy may especially improve outcomes of patients with right-sided primary tumors, and EGFR inhibition with doublet chemotherapy may improve outcomes for patients with left-sided primary tumors. So basically, this is again an algorithm suggesting what to use. If RAS mutation is there, then probably VEGF, anti-VEGFs we can use along with the chemotherapy backbone, looking at all the indications and contraindications for VEGF inhibitors. So if RAS wild type, we need to check whether left-sided tumors or the right-sided. Left-sided, we can add anti-EGFR therapy. And if RAS wild type, if contraindication is there or right-sided tumor, then maybe VEGF backbone we can use. So RAS mutated microsatellite stable MCRC, standard of care for CRC with RAS mutation is the chemotherapy alone, and we can clearly see the prognosis. The PFS for KRAS mutant, the overall response rate in the wild type was 17%, was in mutant, it was not there. So addition of mutant and RAS mutations, benefit of EGFR inhibitors is not there or limited. So the studies done with in RAS mutant, if it was wild type, the PFS and OS we can see 10 and 23.9 in all the prime, opus, and the crystal studies. And if the mutation was there, we can see how it has dropped. So if any RAS mutation was there, irrespective, then definitely PFS and OS across all the studies have come down. So we can use Folfox or Folfiri in first line along with bevacizumab. Each one is equal, no differences in the outcome whether we use Folfox or Folfiri. So RAS wild type, does the anatomical site matter? We have already discussed it is a heterogeneous disease, and site plays a role. So we know that molecularly, RAS, MSI, and BRAF are more common. MSI, BRAF are more common than the right-sided tumors, and KRAS is equally distributed in the right and left side, but HER2 mutations are more common in the left-sided tumors. So again, the same thing, fire 3. In the left-sided tumors, cetuximab had shown benefit, but in right-sided tumors, cetuximab did not show any advantage. So what do ESMO and NCCN have to say as far as the treatment recommendation is concerned in the RAS-RAF wild-type tumor, depending upon the location? This was presented at ASCO 2019 last year. So ESMO says for the left-sided tumors, cytotoxic doublet plus EGFR inhibitor is the treatment of choice. But NCCN does not give any preference of one biological over the other in the first line. But in the right-sided tumors, ESMO says the cytotoxic triplet plus BEV, or like the FOLFOXIRI plus BEV, or a cytotoxic doublet plus EGFR antibody uh, can be used. But in second line, in the right-sided tumors, NCCN says no EGFR monoclonal antibodies in first line, and potentially they say even in the second line, even if the EGFR, the RAS is wild type, we should not be using EGFR inhibitors on the right side. So same based on the SWOG 80405, sidedness and the RAS wild type status, the benefit from cetuximab. If we look clearly, the benefit was there on the left-sided tumors, cetuximab and website, it was the same. Uh, uh, if we look left and right, cetuximab 39.3 and right-sided tumors, it was 13.6. But if we are using left-sided tumors, benefit of cetuximab was more in as compared to bevacizumab. But on the right side, there was no difference. Probably in the right-sided tumor, cetuximab was not that good or harmful as compared to bevacizumab. In the second line, the factors based on which we will be determining to choose our second line treatment is prior treatment with VEGF or EGFR inhibitors will tell us whether we can use them or not. Post VEGF, anti-VEGF therapy, we can still continue anti-VEGF inhibitors beyond progression. And if received prior VEGF more than 3 months after maintenance, we can still use. And again, the genetic and molecular status we need to consider. So if the second line paradigm, if we look at the same chart again, So if we have used chemo plus anti-VEGF, if the RAS mutation was there, we can change the chemotherapy backbone and can continue with the anti-VEGFs. But if we have used RAS wild type anti-EGFR inhibitors we have used and patient has progressed, then definitely we will change the biological and the chemotherapy backbone both. So there is data to suggest VEGF inhibition after progression on bevacizumab, we can continue. And though we don't have much experience with these two agents in colorectal cancer, but bevacizumab is the only agent that we are using. So in the targeting EGFR, what are the key points? The cetuximab and panitumumab may be interchangeable. Molecular markers we need to check for RAS, RAF, and HER2 amplification. There is data generated. If RAS and RAF is mutated, we usually don't give EGFR inhibitors. And now there is emerging data that which says ki HER2 amplification, in the presence of HER2 amplification, EGFR inhibitor therapy response diminishes. Tumor location may affect chance of benefit. No benefit of EGFR monoclonal antibodies in right-sided right-sided cancer, at least in the first line, is not there. So VEGF therapies. So duration of VEGF inhibition matters. Treatment to progression, maintenance strategies, and treatment beyond progression we need to discuss. There is some synergism between fluoropyrimidines and the bevacizumab. Uh, so it was in first line combined with four, and coming to the subsequent lines, the third line and beyond, the options become limited, and even if the options are there, they are not very like good to give. The tolerance is a really an issue. So regorafenib is freely available with us. TAS 102 is not available to us as of today. I do not know whether it is available in Bangladesh. But we usually go for regorafenib. As Dr. Senthil also said, it's not a very good drug to tolerate. And again, the responses do not last long. So regorafenib is a multi-targeted kinase inhibitor. It was this study which compared it with the regorafenib with the placebo, and primary endpoint was the OS. This showed there was some benefit as compared to the placebo, 6.4 versus 5 months. So there was some PFS advantage also, very minimal though, numerically only. So again, so side effect profile, not a difficult, not an easy drug to give. So again, another study whether we can re-challenge with cetuximab or EGFR inhibitors. Reverse showed yes, we can if the patients were previously treated with irinotecan, oxaliplatin, and prior EGFR agents were not given regorafenib, then cetuximab. There may be some reversal of the response or so reduce basically how to retitrate the dose of titrating the dose of regorafenib. Now earlier we were starting with 160 milligram daily. Now we are going with 2 BD first week, then 80 milligram once a week, once a day for first week, 120 milligram once a day second week, and 160 if the patient is able to tolerate in the third week. So again, TAS 102, dosage and administration is there, but practically no experience, not available with us. So recourse was the study which said we can use this. So other options like BRAF mutant cancers, uh, there is like vemurafenib, dabrafenib, and corafenib, and combinations are coming up along with or without metinib inhibitors. But again, I have no personal experience, not used. Then role of HER2 new therapies like we discussed yesterday also, Heracles and Mountaineer, tucatinib plus trastuzumab, they have some role to play. So again, re-challenging, there is one concept of like they say ki with time, the response to EGFR inhibitors may decrease. And if we give appropriate break, then this resistant clones may disappear and we can re-challenge in third line or subsequently. So cricket study had shown that overall response rates after re-challenge with the cetuximab plus irinotecan was 21.4% was there. And ASMO guidelines support the concept of re-challenge with therapy used previously in first-line treatment. And without biologicals also, if like sir had given Folpox, we also re-challenge provided neuropathy is not there for oxaliplatin based therapies. And these are the upcoming strategies in the metastatic colorectal setting. So concluding, so addition of biologicals to chemotherapy has improved the outcomes, but we need more. And definitely identification of molecular predictive factors is improving. And still there is a lot of scope, and we do not know how to titrate, and the effective drugs needs to be discovered. The attempts are underway to expand the role of immunotherapy beyond treating patient with MSI, which I asked sir what he will do as of today. But data is there, but not robust enough as of today. And ctDNA, maybe it will help us in giving us more precision to the treatment. Thank you.